Good afternoon. Thank you, panel, for coming back to the meeting room. We appreciate that. I have something I'd like to read on behalf of the Legislative Finance Committee, and if I could have everybody's attention. The New Mexico Legislature, having learned of the retirement of Stephen McKernan, does hereby extend its recognition. Whereas Stephen McKernan is retiring after 37 years of dedicated service to the University of New Mexico Hospitals, Health System, Health Sciences Center, and the people of New Mexico, and whereas he received a bachelor's degree from St. Bonaventure University and a master's degree in economics from the University of New Mexico, and whereas he is married to Rebecca, an advocate, an advanced practice registered nurse at UNM, and together they have 4 children, and whereas he has worked for the accounting firm of Deloitte, Haskins & Sells and is a certified public accountant, and whereas Steve joined UNM Hospitals in 1980, he has held numerous leadership roles in finance and accounting, and in 1996 became its chief executive officer. And whereas under his leadership, UNM Hospitals has flourished into a respected academic medical center and safety net hospital, including a network of community-based clinics and educational programs focused on nursing and rural community outreach. And whereas he has also served as Chief Operating Officer for the UNM Health System, which spans 2 hospitals and other clinical delivery system components that serve more than 250,000 New Mexicans each year. And whereas Steve is recognized nationally throughout the hospital community, serving on the board of American Essential Hospitals, the National Association of Public Hospitals and Health Systems, the University Physicians Association, and Tri-West Healthcare Alliance. And whereas he is also an active member of his community who participates in local groups such as the Rotary Club, the New Mexico Hospital Association, Tri-Corps Reference Laboratories, and the Boy Scouts of America. And whereas Steve has been an outstanding advisor to the members of the Legislative Finance Committee and the New Mexico State Legislature in collaborating and creating a roadmap to continue improvement and access to health care for all New Mexicans. And whereas he will be remembered for his tireless leadership in maintaining the stability and sustainability of UNM hospitals while never wavering from his goal to provide New Mexicans with access to excellent health care. Now therefore be it resolved by the legislature of the state of New Mexico that congratulations be extended to Steve McKernan upon his retirement from the University of New Mexico Hospitals, signed and sealed at the Capitol in the city of Santa Fe by myself, Senator John Arthur Smith, and our 2 chief clerks. Where is Steve?
Get in the picture here.
Can you make a picture of
And what it says is, in recognition of your many years of service and dedication to the people of New Mexico and University Hospital from the Legislative Finance Committee. Thank you for that, indulging us, and we mean it from the bottom of our hearts, and we appreciate it, all the work you've done for us in this state. So with that being said, we're going to go ahead and jump right into the presentation.
Thank you, Madam Chair. Hopefully, I will be able to live up to all those accolades. I very much appreciate that. But do also want to recognize at UNM, we have just a phenomenal team of people that are all just as dedicated to serving these people up in Mexico, and there's just no way in the world they do it without that entire team. So I appreciate it. What I'd like to do today is try and weave a story from the perspective of UNM about how we see the direction of healthcare being delivered, especially as it relates to Medicaid, and some of the things that are very important in that regard. The first thing I'd say is that there's one rule that we believe is very, very important. We can either call it the 550 rule or the 2080 rule. In any year, 5% of your population is going to use 50% of your healthcare spend, or complementary, 20% of your population is going to use 80% of your healthcare spend. So if you're going to deal with healthcare expenditures, which I think is one of the core fundamental issues, what you have to do is figure out how to deal with people that are at the 5% or 20% level, because that's where all the spending is. Most of that is related to, not exclusively, but a lot of it is related to people with complex chronic illnesses, hypertension, diabetes, those type of things. And we have to create systems to be able to take care of those patients and get good results. The second thing I focus on, and try and bring this back at the end of my discussion today, is at UNM we believe that all healthcare is local. That's where the delivery occurs. There's all kinds of stuff about national problems and stuff like that, but if you are going to build a program, you're going to have to build it at the local level. That's where people seek the care. And if the issue is related to the 5% that use 50% of their health care spend, you're going to have to deliver that care at the local level. What got us to this point, and you'll probably see this, I'm not going to dwell on this, is that everybody knows the United States has the highest healthcare expenditure in the world for industrialized countries, over 17%, but our outcomes are amongst the poorest of Western industrialized countries. And so that's really got us where we are as people trying to figure out why do we spend that much money and get poor outcomes instead of good outcomes. And what I want to try and do is address why I think we're at that situation and what we might do to help with it. In the United States, that's evolved around to something that's called the triple aim as a methodology to help with that. And triple aim means that you can provide better access and outcomes for patients, you can deliver better service, and you can deliver it more efficiently at a lower cost point. Where we see the biggest trend occurring on this in the United States is actually with Medicare, not yet with Medicaid, and mostly with Medicare Advantage programs. And we see that very much in Albuquerque, where 65% of all the people in Medicare are now engaged in or enrolled in the Advantage program. And for those Advantage insurance companies like Presbyterian and United and Blue Cross, when they come to provider organizations like UNM, they have a whole lot of criteria that is important to them. One is they want to make sure we're a high quality provider. They don't want to contract with low quality or poor outcome providers. That's pushed us to make sure we can document that the care we provide is superior. It's got to be better than half of the other hospitals in the United States. That's the way they set up their rating system. Additionally, they make sure that we do locally in the hospital that the patient is assigned to, or the provider of the patient assigned to, is an assessment each year. And they have a special system called HCCs about how we evaluate those patients. And we must understand what chronic conditions they have, and we must develop a treatment plan for that patient. Then we must be able to demonstrate that we are making progress with that patient on that treatment plan. That is a very aggressive way to administer healthcare in the United States. more like the European model, and we're seeing that advancing throughout the country. Again, it's especially going on in Albuquerque because we have such a high proportion of our Medicare population in that group. What we have developed at UNM to try and deal with that is a comprehensive system of healthcare delivery. So when we talk about comprehensive systems, and again, we're going to be able to contrast this, what we can do in an urban area versus what we do in a rural area. But at UNM, it looks at pre-acute care, acute care, and post-acute care. So when we talk about pre-acute care, it's all types of things like pre-care, clinic visits, wellness care, those type of things. When a patient gets an acute care episode, then they can get admitted to a hospital, have a surgery, or have some other type of therapy, so for cancer, chemotherapy. And then post-acute care, where we work with skilled nursing facilities, rehab hospitals, again, clinic visits, home health, those type of systems. What we've had to do at UNM is effectively build that or partner that entire continuum of care within our system. So we can have enough control over the care of patients that we can assure that the patients get access in the AAA model, they get high service, and we give them a quality outcome, and we do it more efficiently than we've been able to do it in the past. Some of the infrastructure we've had to build is unbelievably expensive. We have built about 15 community-based clinics. We have invested enormous amounts of money in an electronic medical record. In that electronic medical record, we have supplemented it with population health software so we can track large groups of populations over time and when they are outside of our system, and be able to determine what care they received, what care they did not receive, and what their outcomes were. This software also allows our providers to be prompted when a patient comes into clinic about whether they had their screening exams. Are they getting their blood pressure checked? Are they getting their A1C blood sugar score? Are they being tested for asthma? Did they pick up their medications at the drugstore? All these type of things we can now track for our patients. We've developed patient-centered medical homes, which allow us to look at the patients in a different way. Instead of having the patient come in for a doctor's visit, the doctor orders a bunch of labs, then the patient gets the labs 2 weeks or 2 months or 4 months later, and then the doctor calls them up and tells them what the labs were. We get the labs and all the diagnostic tests before the patient comes into the clinic, so the patient and the physician can have a good interaction. They can come up with a care plan. Then we turn that over to nurse case managers who help manage the care of that patient, and we supplement that with navigators. We also supplement this with mental health professionals, psychologists, psychiatrists, and other folks who can start dealing with some of the behavioral issues and look at the drug substance abuse issues that are going on with the patient. Because at the end of the day, our job is to get the best outcome for that patient. These systems are extraordinarily expensive to build. We're able to build them at UNM because we have the capital to be able to do it. We've invested in this in the long term. We have taken near 20 years to build out this model very slowly, but we have been able to get to that point. Our patients love this model, but it is very expensive to run, and at the current time, as it relates to Medicare and Medicaid patients, we lose enormous amounts of money running this model. What we believe needs to happen and where we think the evolution is going, we hope those little faster things right now, is new payment methodologies to help us focus on the care before people become acutely ill, and to focus on the care after they've had the acute spell of illness to help them recover, get back on their feet, and get to their best optimal state. Right now, as you know, we still are principally in a fee-for-service market. Fee-for-service market effectively rewards the care of tertiary illnesses. If somebody has cancer, if they're a neonate, if they're in a trauma, if they need a transplant, those type of things are actually paid very well. What is not paid very well is all the things I just talked about before in the patient-centered medical home. Being able to bring a patient in, working with the patient, getting them set up for the best visit when they come to the doctor, being able to follow up with them, offering them the wraparound services like psych, substance abuse, having navigators go out, make sure they get their medications, those type of things. They're very expensive and they are not well reimbursed. We believe we are moving towards value-based purchasing, which is a Medicare goal, not Medicaid's working on it right now. Medicare is more advanced on this, where they reward outcomes, but it's still principally a fee-for-service market. The next version after that is a capitated market or subcapitations, different versions of that, where we are paid as a healthcare delivery system for taking care of groups of patients, 5,000, 10,000, 20,000 patients. And we're paid an amount of money per member per month, which would then give us as a provider organization a lot of motivation to prevent that patient from having acute care. Now you can build these in urban areas, they become much more difficult to do in rural areas, we can have discussion about that. But we believe at UNM that's where our focus needs to be, and we've invested a lot of funds in developing this model. Some of the dilemmas that we believe we're facing right now is that there is a lot of rotation in Medicaid for patients between MCOs. So if you're trying to work on outcomes for patients, and in 1 month there was one MCO, and 6 months later there was another MCO, or 6 months or 12 months later there was a third MCO, what motivation does any organization, whether it's the MCO, I'll let them speak for themselves, or the provider organization, to invest in preventative care, bring patients into patient-centered medical homes, and try and deliver this care, because you don't know what organization they're going to be insured with a year from now, 6 months from now, a year from now, or 2 years from now. It is very disruptive to the healthcare providers because each MCO will have a different set of rules, a different set of reimbursement mechanisms, and a different network of allowing patients to access the system. After that, we have to deal with attribution. Between the MCOs and the hospitals, there is not good attribution. Which patients belong to which healthcare providers? Now, this may seem like a mechanical thing that can be easily solved. It is not. You need patient cooperation in this. When you have a system where patients don't have financial disincentives, i.e. they don't have co-pays, well, they can go to almost any place, any provider, and get their care, so they go outside network, so attribution becomes very difficult. To give you an example of how attribution can become difficult is if attribution model defaults to, for instance, the last 3 times a patient had a visit, what system did they go to? What happens, for instance, at UNM, if the patient has cancer, the last 3 visits is UNM's cancer center. If you go to a capitation model where you're getting paid $500 per member per month, and the only patients you're getting are cancer patients, it is not going to be a model that will survive. The incentives are mixed up. So attribution of patients becomes very important. Pre-authorizations become very important. If you're a healthcare provider, you go to a system, you ask them for pre-authorization, you get the pre-authorization or not. When the patients come to you, you have to treat them. And that's our licensing and law requirements in the United States. If they don't have the pre-authorizations, frequently you still have to treat the patient, and then you have to try and clean it up later. It uses a lot of resources, and frequently you do not get paid as a provider. And again, being able to provide local care where people are attributed to, enrolled in a local provider, they know who their doctors and nurses are, they know where their clinics are, and they feel like they belong to that clinic, and they don't move around a lot, is one of the keys to success in this system. So just to make some final closing remarks, we believe a system in which it is based on the triple aim, getting better access and quality of care, better service, and being more efficient is very, very important. That the 550 rule is going to drive everything in the future so we can get those patients that are chronically ill with very complex conditions into providers in networks where they're going to stick in those networks for long periods of time, and whoever the payer is, the state of New Mexico, Medicaid, or whoever, can look at our outcomes for the patients. And if we're not doing well, we should get a penalty for that. But if we're doing well, we should be rewarded for caring for those patients very well. And that we look at populations, groups of patients, and try and make sure for large groups of populations, we can exhibit very good outcomes in a very efficient manner with high service for those patients. So those are the systems we're trying to create at UNM. We think we're on our way to doing it. Our observation is the payment models are not synced up with the delivery models right now, and we believe that an emphasis ought to be trying to sync up those models so that the providers, which eventually at the end of the day are going to be people treating the patient, I mean that's self-evident, they can get covered for their costs and rewarded for providing good outcomes for patients. And you can have an idea of those providers that do not provide good outcomes, and then you can deal with those organizations. With that, I'll be happy to take questions now, or just wait until the panel
Why don't we go through the whole panel, and then we'll come back to questions.
Thank you, Madam Chair.
I think it's me, so let me introduce myself. I'm Chuck Milligan. My day job is I'm the CEO for United Healthcare's local New Mexico Medicaid plan, and also in my plan are some Medicare Advantage members. But that's, I think, not the main reason I'm here. I'm also a member of a federal commission called MACPAC, and I wanted to give you all just some perspective on what's been going on in Washington, D.C. And in terms of your budget planning, your scenario planning for New Mexico, I did want to share a little bit of my perspective from the Washington, D.C. Medicaid and CHIP debates. So there is a presentation I put together. The bulk of my time is going to be about the federal conversation. I will conclude with just sharing with you United's national perspective on this. But I'm going to start with page 3. And again, this is probably thicker than you might be hoping to see, but I'm going to kind of breeze through a lot of this, and we'll see where we go with the questions. So background on MACPAC first. MACPAC is an acronym. It stands for the Medicaid and CHIP Payment and Access Commission. And it was created by Congress in 2009 during one of the reauthorizations of the CHIP program, which is a kids' health program. MACPAC consists of 17 appointed commissioners, appointed by the Comptroller General of the U.S., who's the head of GAO. We're each appointed to rolling 3-year terms. I'm in the 3rd and final year of my term. There is a full-time executive director and staff that work on Medicaid-related and CHIP-related research and scenarios all the time and data. Typically, we meet for 6 to 7 public meetings a year. We're going to be meeting again in September to talk about federal budget and CHIP. But MACPAC is, you can see I provided the website. It is the only federal body appointed to advise Congress on Medicaid and CHIP. The next page on slide 4, and I won't go through this, I won't read this to you, but the purpose of MACPAC in the federal statute is to review the policies of the Medicaid program and CHIP, to make recommendations to Congress and the Secretary of HHS, and to the states concerning policies. There are a couple of annual reports that are expected that include research and recommendations. There's a report about implications and changes in healthcare delivery, payment reform, access to care, quality of care, all of those kinds of things. There is a report about the disproportionate share hospital payment program, which is a supplemental fund that goes to safety in the hospitals, and to otherwise make recommendations to Congress and the Secretary of HHS on access, quality payment policies, all of that, Medicaid eligibility. So in our sessions, the next one is in September, we meet with the staff for the Medicaid committees of jurisdiction, so House Energy and Commerce, Senate Finance Committee. We meet with the CBO, we meet with leadership from CMS and HHS, and we end up making a recommendation. So that's, and on one of the 17, I think that's really where I was asked to try to add value to the LFC's deliberations in the budgeting for the state. So I'm going to just talk through, beginning now on slide 6, there's 3 different payment reforms at the federal level that are often discussed about how the federal government changes its budgeting for Medicaid and CHIP. The first are block grants, which tend to be pretty well known. The federal government provides a certain amount of money. Typically, there isn't a state match required, although, as we've seen with welfare reform and other examples of block grants, there is a state maintenance of effort requirement, so it's not free to the state, but the federal government says, you're going to get, $1 billion and that's it. That's block grants. The second form of federal payment reform is on page 7, it's capped allowance. And the gist of this is, it's a matching program. When the states pay, the federal government matches it, but up to a cap. And when that cap is reached in terms of the federal spending for a given federal fiscal year, adding state matching dollars is not going to draw down more federal dollars, it's capped. And this is how the CHIP program works currently. The state contributes matching funds, the federal government matches it at a matching rate, but it hits a ceiling, there's a cap to that, you can't draw it down infinitely. That's the CHIP program. The third version of federal financing reform is what's known as per capita caps. And what this means is the federal government will pay matching funds for every Medicaid eligible person, and so the state is not at risk if the Medicaid enrollment grows, because the federal government will contribute matching funds for each person, but the amount of that is capped at the per person level. So for example, and there's some examples to come, if the federal government's going to pay $2,000 a year for kids, it'll be a matching rate up to that point. Adding more kids is not a risk to the state because you'll get the $2,000 per kid regardless of enrollment, but it's not going to be more than $2,000. And so if the healthcare spending, in fact, is $2,500, the feds are only going to send $2,000. That's per capita caps. At a high level, those are the 3 financing reforms that are under discussion. So let me now go, and I'm going to jump to slide 10, to what was inside of the House version that in fact was passed by the House. So this was the House's version, the U.S. House, to repeal and replace the Affordable Care Act. CBO did estimates that it would reduce the federal outlay to Medicaid by $834 billion over a 10-year budgeting window. It would lower Medicaid enrollment by 14 million or 17%. And just, I have one bullet to show the New Mexico impact of that. And this is a CBO estimate, it's not a United estimate, so just to be clear about where the numbers come from. The CBO estimated, and they did a state-specific estimate, that the federal government and the House version would reduce the federal contributions by about $11.7 billion over 10 years based on a set of assumptions that CBO built in. This passed the House in early May. Moving on to slide 11, implications of a Medicaid expansion is that the states could continue, that had the Medicaid expansion like New Mexico could continue it. It would be optional. It would eliminate the state's ability to go above 133% of the federal poverty level. It would prohibit new states from expanding that hadn't before. But it would change the matching rates. And so the state could still do the Medicaid expansion, but the matching rate wouldn't be as favorable to states as under the Affordable Care Act. So beginning in 2020, the matching rate would get stepped down by the federal government, look more like regular Medicaid instead of higher for the expansion group. And for the people on the Medicaid expansion, those individuals covered by the Medicaid expansion, their eligibility for the expansion would be grandfathered, and the rate would continue for them if they had continuous eligibility Medicaid before those rate changes. But I'll talk about that in a second. Next slide, please, and just some additional Medicaid implications in the House version. There were a couple of things that Congress did to try to make it harder for people to stay on Medicaid in terms of how certain assets and resources were treated. I gave one example where they really wanted to make sure that lottery winnings were treated differently than the way states treat lottery now. It would eliminate retroactive eligibility. The way it works now is if somebody applies for Medicaid now, they can reach back a few months, and if they're financially eligible for Medicaid back a few months, their eligibility Medicaid would backdate a few months and cover whatever costs were incurred going back a few months through Medicaid. The House version would eliminate that retroactive eligibility span, which would actually increase uncompensated care and uncovered care to places like UNM Hospital, because if somebody goes into the hospital because of a trauma and is uninsured but eligible for Medicaid and would have been eligible 3 months back, they could apply, get their Medicaid ID card going back, it'll pick up the costs and cover those uncompensated care costs. The House version would eliminate that. It would make it harder to do presumptive eligibility, which is a way of giving people a Medicaid card based on their self-attestation of their poverty level while it's pending the actual determination. It would eliminate certain requirements about covered benefits. This next bullet about eliminating requiring 6-month eligibility redeterminations. The House version would make the states renew eligibility every 6 months, so people had to prove, yep, I'm still poor, yep, I'm still disabled. And this was the House version of making sure that people didn't stay on if their income changed, but the effectiveness in some states that have done this is fewer people stay on Medicaid, because if you don't reapply, if you don't bother, you fall off the rolls. It would include a state option to make a work requirement for Medicaid expansion. It would do some of these disproportionate share hospital cuts in places like New Mexico that did the Medicaid expansion. In the Affordable Care Act, and I'll slow down how quickly I'm talking. In the Affordable Care Act, the notion is if people get more Medicaid coverage, there are more people insured, there's fewer supplemental funds needed for uncompensated care to cover the costs at places like UNM. So the ACA was going to step that down. The House version maintained that and then kind of restored some cuts. On slide 13, the House version would say states have to pick between the block grant or per capita caps. I mentioned what those two are like. So a state could say, yeah, we want a block grant. We'll get more flexibility if we do a block grant. Not pure flexibility, but the state would have more flexibility. Or the state could do a per capita cap and be subject to the same requirements as currently about waivers and state and federal approval of state changes. But even in the block grant, you'll see the bottom of slide 13, there are certain mandatory populations and mandatory benefits, even if it was block grant. In other words, states didn't have pure discretion, more discretion. So the House version would have said you get to pick block grant or per capita caps, one or the other. So let me just go through some of the key financing elements of this, and these kind of apply to all per capita caps and block grants. So I'm going to go through, I'm now on page 15, and these are the design elements, and I'll give a couple of examples briefly in terms of if you establish a per capita cap, or if you establish a block grant, these are the features that really dictate the impact at the state level. The first is, what is the base year? So what is the jumping off point for how big the block grant is, or how much the per capita spending is for a kid? The second important design factor is what's the growth factor, which is what's the inflation rate, what's the trend. So you take the base and grow it, and the federal government will set that growth rate. That also is an important design feature. The third design feature, what does the federal government carve out of all of this and just treat like the status quo? Because the federal government could say, we're going to treat DISH like the status quo. We're going to treat IHS and coverage for Native Americans like the status quo. We're going to treat administrative costs at HSD and other agencies in the status quo matching rate. And so what gets carved out and treated traditionally is also an important design feature versus what costs are baked into the block grant or per capita cap, and then there are some state-specific elements. So let me just mention, I'm on slide 17. So this is the first design factor, which is picking the base year. This is actual data from MacPac. Each of those gray kind of shaded lines is a particular state. This is real data in terms of that state's fluctuation in spending year over year in Medicaid. You can see the green highlighted is one state, true numbers. Another blue highlighted is a second state, real numbers. And so if you picked as your base year 2011, the state A, the green state, would be gangbusters. They had a high spend. They could trend that forward. They would be happy. State B would not be happy. State B would be happy with 2012, where their spend was high. And so there's a lot of state-specific impact by how the federal government would pick a base year. That's design feature number one. The next part about picking the base year, though, is if you look at the next slide, slide 18, picking the highest spending year isn't necessarily the best year for states. Because if the trend factor that the federal government picked was higher than what New Mexico's actual inflation was, you might want an earlier base year because the federal government would trend that into fiscal 18 or fiscal 19 at an earlier point in time and use the federal trend rate, which might have exceeded what you actually spent in those intervening years. So picking the year that's the highest spend, but it maybe is a recent year, isn't necessarily in the state's best interest. If picking an older year with a higher trend would have gotten you to a higher result. Okay? So it's a combination of the base year and then the trend factor. But the base year is the first design element. The second design element is choosing the growth factors. So now I'm on slide 20. These were a set of the growth factors that were discussed by Congress in both the House and Senate versions. It could have been using Medicare price changes over time. It could have been using private insurance. It didn't use those. None of the versions used those. What was in discussion was using a price inflation factor like CPI, Consumer Price Index, for urban consumers. So that's referred to as CPIU. A second version is using the Consumer Price Index for spending on medical things, which is different Consumer Price Index than just a basic CPI. That's referred to as CPIM, the medical care component of what's inside the Consumer Price Index. And then the other version that was discussed by Congress was using GDP, so the growth in the federal gross domestic product. On slide 21, you'll see how these different trend factors were varying year over year, and this will be an important data point for actual Medicaid spending. So if you look at CPIU, that tends to be low. If you look at just the current year, so we're still in federal fiscal 17. Federal fiscal 17 ends at the end of September. CPIU is 2.4%, CPIM is 3.8, GDP is 4.2. If you picked one of those and made that the permanent trend, from now on, there's a lot of impact to states about how the federal contribution will grow over time and what that growth factor is. Okay, I just want to give you an example on slide 22 about how this might play out. If we use, so I'm going to just walk through, these are different federal fiscal years. This is part of the CDO analysis that was part of how the House version was passed. CPIU is in the far left, 2.6%, all of those hypothetical years. CBO estimated that the total spending in Medicaid for kids was going to be going up 6.2%. 1.4% of that growth is just growth in enrollment, not growth in price, growth in enrollment. The next figure, so that's the 1.4%. The next figure is the spending per enrollee, CBO's estimates of 4.8%. And so if, for example, CBO is right, the total spending would be growing for kids in 2021 by 6.2% as a factor of enrollment growth and price growth or payment. But if the federal government's contribution is only going up by 2.6%, states have a choice to make. Do you come up with the difference of state dollars, or do you cut Medicaid in all of the different tools you have to cut Medicaid? And one of the reasons CBO estimated a reduction in Medicaid enrollment, fewer people covered, was because states would do cost containment actions in the face of this that would eliminate eligibility or add cost sharing and premiums, and people wouldn't pay them, and that enrollment would go down because of states' response to this budget cost shift. And you can see on the right the same effect for adults. So that's kind of the big picture of trends. Now, on slide 24, I've got examples of how a per capita cap would look. These are, again, CBO actual analyses presented to MacPac. I've circled in red at the bottom kind of the four major groups that CBO is looking at. Kids, nationally, the federal government was spending about $2,800 a year. Adults, about $4,200 a year. Non-disabled adults, $4,200 a year, I should say. So this is like TANF populations, not disabled adults. With adults with disabilities, CBO estimated about $18,000 a year federal spending. And then aged, so this is poor seniors, not necessarily disabled, about $15,000 a year, plus or minus. And so in a per capita cap world, pick your base year, pick your trend, you would get that amount for these different groups. Adding enrollment in these different groups, if you could manage inside of the trend factor, you're fine. The federal government will keep contributing per person, okay? If the trend matches the actual spend, you'll keep getting the same money from the federal government per person. But there is an important thing to look at, which, and we can skip over slide 25. I just mentioned again, kind of this is how the per capita cap populations were defined. But I do want to give one example on slide 26. So let's say the Reform Act that was passed by Congress said, we're going to give you a limited amount of money per kid, per capita cap of, say, $2,800 trended. For a given state, depending on how you're, of the mix of kids, you could have a situation where if you're growing newborns faster than you're growing 16-year-olds, the newborn cost, regular newborn cost is the $9,000. Newborns with disabilities, $95,000. If you're growing newborns faster than you're growing other kids in the mix of kids, a per capita cap isn't going to address that. So for some states, getting a per capita cap of kids, $2,900 a year trended, it also has impacts based on demographic growth within that state about Medicaid picking up maybe more newborns in the overall mix of kids, in which case that per capita cap is going to be insufficient because newborns cost more. And Congress wasn't talking about a more nuanced view of per capita caps. Kids, adults, disabled adults, poor seniors. Okay? So that was just an illustration. I wanted to conclude kind of the federal stuff. So we all know that the Senate didn't pass anything. There's been a lot of debate about whether they're going to try, Congress is going to try again. Eventually, Congress will try again in some form or another. In some form or other, Congress is going to have to take on entitlement reform. Depends on when, depends on what form, depends on how, but this is the basic design of it. Block grants, capped allotments, per capita caps, base year, growth rate, carve-outs, state impacts, okay? Meanwhile, at the executive branch side, so never mind what Congress is doing, but at the federal level, at HHS, Secretary Price sent a letter out to the states, and CMS Administrator Tima Verma is sending out guidance to state Medicaid directors saying, these are the kinds of reforms we will entertain in a Medicaid waiver if you want to pursue them. We invite you to think about these things. So at HHS, never mind federal reform, from Congress, HHS is saying we are extending an invitation for you to consider Medicaid reform that we can do inside of a Medicaid waiver. They have invited states to think about things in a couple of, and I've simplified this a little bit, but I bucketed it in two main ways. One is for Medicaid to look more like commercial insurance, so that there would be no retroactive coverage at all, meaning if I apply for Medicaid today, August 16, the soonest I would be eligible is September 1st. Because like employer insurance, it's the first day of the following month, and Medicaid isn't going to cover my costs this month, or last month, or the month before. Just like employers, it's you enroll prospectively. HHS is also inviting states to think about a more commercial-like benefit package, and to think about Medicaid benefit redesign, and to think about Medicaid out-of-pocket. More commercial-like, thinking about co-payments, home insurance, premiums, that sort of thing. The other dimension to what Secretary Price has invited states to think about is elements that look like welfare reform. So things like potential work requirements for Medicaid expansion adults, potential drug testing, annual drug testing for Medicaid expansion adults. That invitation's out there, but states are completely free to ignore the invitation and just run the program this way the state's running it now, the way the state wants to do it. HHS cannot mandate the adoption of any of that. Okay? That is an invitation for waivers. There's nothing that requires any state to go there. And many states will not go there. Okay, so I just want to mention briefly, in the interest of full transparency, United Health Group, and then I'll stop. This is a national, so I'm going to just begin at the first substantive slide. I will begin on slide 31, just to highlight on the right. This came out in the summer of 2016, before the election last year, before United knew who was going to be elected, before any of the discussions in Congress. So this wasn't a reaction to any particular election results. This was United trying to lead with a position in general. So this is the national effort. So the first, and I'll go to slide 31, again, interest of full transparency about my day job, improving access to care and allowing more state control of healthcare solutions, and more state flexibility and state design, and not as much federal constraints. And to stabilize coverage, the second bullet on slide 31 is really targeted more at the exchanges around the country, and to make sure that federal government shored up a lot of the payment subsidies for low-income adults, to help make sure that some of the risk protections in the Affordable Care Act were shored up and stabilized to stabilize coverage. On slide 32, United took a position that the federal government should eliminate some taxes that were in the ACA, should pay for value, very much like what Steve said, that we need to, as a country, get away from paying for volume and units and fee-for-service, for paying more for outcomes and quality and excellence. And so that's clearly United's position. And empowering consumers, what United sells to employers and to its own employees like me is a view of having empowerment to make good decisions ourselves. For employers with employees covered through United, that takes the form of things like health savings accounts, takes the form of benefit design so that individuals covered have more, they're better consumers. And to echo a little bit of Steve's comment about co-payments. We don't want somebody going to the emergency room if they could go to urgent care, if they could go to their primary care provider, if it's timely and available. We want people to make good choices. We want to make people make good choices about picking the generic drug if it's less expensive than the brand drug. So that's part of what empowering consumers means. United has a position about making prescription drugs more affordable. United has seen, as you all have seen, with a lot of expense, with a lot of drugs, that there needs to be reform of pharmacy pricing, pharmacy management, and it's stressed a lot of state budgets about a lot of the prices and price rates. There's positions United has about FDA approval and generic market. On slide 34, United has a position about shoring up Medicare Advantage, less relevant to this particular audience. And then I will conclude with slide 35, reinvesting in health. So creating a 21st century healthcare workforce. New Mexico is actually really far ahead of the game in this, and this really means empowering mid-levels, changing some licensure views, letting people work to the top of their license. New Mexico has gone there in many ways progressively about nurse practitioners, physician's assistants, psychologists, and many others. This is a push to help expand the workforce by really leveraging and thinking through licensure, training, education, top of practice, top of license. United believes in investing in medical research. Accelerating interoperability is making more things automated and using electronic medical records and other tools in better ways, and then prioritizing prevention. That was a lot. Thank you for your attention. I will now turn it over to Brent.
Thank you, Madam Chair, members of the committee, and Brent Ernest, Secretary of Human Services Department. You should also have a presentation in front of you, has our logo on it there, and I just want to start out by saying thanks for inviting us here today at Taos Ski Valley, one of the beautiful places in our state. Although I think it's probably the first time I've been here in a coat and tie. Happy to be here nonetheless. So I will talk to you today about the very thing you asked us for, which is Medicaid reform, controlling costs, and improving quality. That's what we think about pretty much every day at HSD in the Medicaid program. Something we've been working on the last 4 years, and something we're going to report to you about today in some detail. So we'll talk about Centennial Care, which we launched in 2014, really focusing on how do we improve quality and lower costs in the Medicaid program. We're going to talk about where we're headed with Centennial Care 2.0, which is the next labor agreement we will be pursuing at the end of this year to the end of 2019. We have 5-year labor agreements with the federal government. I'll give you just a little bit on the federal outlook. Chuck did that in quite a bit of detail, so I won't go into that, but some of the things that we're thinking about as we look into the next budget cycle as well. So, just to take you back a few years to as we launched Centennial Care on slide 3, we looked at a system that was pretty fragmented, that didn't focus enough on quality, that was paying for healthcare services in this fee-for-service environment that we thought was ineffective, and was not centered enough around individuals. So we have really looked to reform the system to really drive care at the right place, in the right setting, the right time. Think about how to purchase the quality of healthcare. How do we slow the rate of growth in healthcare? How do we pay providers for value, as I talked about, in those outcomes? And really, how do we involve members in their own healthcare and making their own personal healthcare decisions? So in slide 4, this gets articulated in 4 key principles. Really developing a comprehensive service delivery system. So we had, prior to this, 7 managed care organizations with specific duties. Now we have 4 managed care organizations responsible for the full continuum of care, from newborns to nursing homes and from behavioral health to long-term care and physical health services. At the core of that is a robust care coordination system, which, as Steve has pointed out, needs to focus on high-risk, high-cost individuals to help them drive better outcomes, keep them healthier and out of the hospital and other acute care settings. Second component of this was bringing additional personal responsibility and member engagement into their Medicaid system. So there's a system of incentives and disincentives that we'll talk about, some of which Chuck has mentioned. Bringing in co-pays for using the ER when it's not an emergency, choosing a brand name drug when you don't need it. Also payment reform, and Steve is absolutely right, Medicare has moved faster than Medicaid in this arena, but we have pushed very hard to bring more value-based payments from the Medicaid system to providers who can accomplish better outcomes for patients and get paid for that. And we'll talk about how we look to do that in even greater, a greater effort in 2.0. And then administrative simplification. So how do we make the system work better for the state, for providers, and for the members who are enrolled? So the next few slides will lay out for you what we've done in each of these areas. So on slide 5, when we look at creating a comprehensive delivery system, as I mentioned, it's about building that care coordination infrastructure, particularly for members with complex needs, in that integrated and person-centered system. So we have more than 950 care coordinators employed by the managed care organizations, 60,000 members engaged in those higher levels of care coordination, focusing again on that high-cost, high-needs individual. Everyone who comes through the system tries to get a health risk assessment done at the outset to really identify those healthcare needs early and tackle them early. We standardize that across the managed care organizations. Increase the use of other care professionals, if you will, community health workers. As you know, there's a certified community health workers program here in New Mexico. About 100 of them are employed by managed care organizations, extending this care coordination function down into communities across the state. More than 300,000 members are enrolled in patient-centered medical homes, receiving services now through patient-centered medical homes. Steve talked to you about how important those systems can be. We've launched 2 health homes, which are focused in New Mexico on individuals with serious mental illness, really bringing both physical health, behavioral health, and that care coordination function all the way down to provider level, and ensuring that care is coordinated and at its highest quality level. One in San Juan County, one in Corrections. We expanded the home and community-based services. We'll talk a little bit about this in the next chart, and we've also seen a reduction in the use of ER for non-emergent situations. Slide 6, component here is delivering this system to all of the states. So as mentioned, these systems work well in urban areas, but more difficult in rural. So we have been able to invest and expand in telehealth, really been partnering with our managed care organizations, so a significant increase in the use of telehealth across the system in Medicaid. The chart on the top right there, just the expansion of the members served in patient-centered medical homes. And the chart on the bottom showing you what percentage of individuals in our long-term community, long-term services and support system are being served in the community. So increasing from about 80% in 2009 to almost 87% in 2016. So people have the choice and are able to stay in their homes receiving services instead of going to a nursing facility. New Mexico leads the country, is among the top 5 in the states in the country in this area. Slide 7 just gives you a little bit more about what we've done to bring some personal responsibility and encouraging member participation in their own health care. The principal component of this is something we call Centennial Rewards. It is a rewards program for engaging in healthy behaviors. So you'll see at the top there on the right, if you do your health risk assessment, you have your annual dental checkup, you get your bone density screening if it's necessary, you refill your asthma inhaler prescription if you have asthma. You have your diabetic screenings. All of those things which help to ensure that you're going to be as healthy as you can be. There's some benefits earned, some points earned that you can then go reward those points. We've seen some good success from this. It's somewhat unique in the country in that it is a statewide system used by multiple health plans. This has been done in commercial products in other parts of the state, but usually by one insurer or for one population. With a very high participation rate, about 70% of our members participate in this program. estimated savings about $23 million for some of the reasons you'll see on the next slides. Slide 8, you see that those participating in the member rewards program are much more likely to comply with their regimen for diabetes. So they'll have their lipid test and their HbA1c test done. So those orange bars represent those who are participating in the program. The next slide, those who are schizophrenic or bipolar have much higher compliance with their medication regimen. Those who are participating in this program are complying at a much higher level. All of which, and many others, result in slide 10. You see fewer inpatient admissions to the hospital among those participating in the program in the orange bars on the left compared to those non-participants on the right. All of that is a component of how do we engage members again in their own healthcare decisions so that they so we drive a better result in terms of outcomes. The next slide on slide 11 is a little bit about the payment reform efforts we've launched in July 2015. The managed care organizations launched about 10 pilot projects that are varying degrees of payment reform projects that payers and providers can undertake together. Developed some reporting from that, and that has continued. This has been one of the more challenging and slower than we expected reforms that we launched in 2014. It is difficult. We have in 2017 a requirement that all managed care organizations achieve 16% of payments in these value-based payment models. We think will drive that decision for all the reasons that have been mentioned to you today. Lastly, on these principles, simplify administration. A lot of activity here and something we will continue to work on probably here and forevermore in Medicaid programs. We consolidated at the state level 11 different waivers, bringing this into one single 1115 global waiver for the Medicaid program. Created a single streamlined application for those applying for Medicaid with the Health Insurance Exchange. Streamlined our enrollment processes, added some online functionality. Worked with providers on improving credentialing and prior authorization requirements, and continue to do that work with providers today. Which leads then to slide 13, and you've seen me present this chart or something like it in the past. This comes from our dashboards that we track quarterly and present to our Medicaid Advisory Committee. And what you can see here on the top highlighted percentage there, you see 5%. That's 5% growth in a 12-month period from April 2016 to March 2017, compared to the 12 months before. The highlighted number on the right towards the bottom is a negative 1%. So our per capita costs are down 1%, even though our enrollment growth is up. So down from $503 per member per month to $497 per member per month. A big component of this is driven by the utilization change, part of it from fewer inpatient hospital stays, more services being delivered in primary care clinics and earlier on. A component of this is also, in this presentation, some of the rate reductions that occurred on last year. I'll also draw your attention, though, to the middle 1%, which is in what we call aggregate non-medical costs. So what we pay to manage care organizations includes things for administration and care coordination. Also built in here is the high-risk pool assessment. So that went from $53.6 million to $61.9 million, 15% increase. And the premium tax also growing 6%. But our admin costs in the managed care dropping 5%. Well under the 15% threshold that's required, the 85/15 medical loss ratio that's required in Medicaid, down around about 9–10%. So slide 14 then presents just a little bit of our big picture that we've talked to you about over the years, which has been enrollment growth. And you can see that in that top presentation in June 2017, about 915,000 individuals enrolled in Medicaid. We have seen, actually in the last few months, a flattening of that projection. And you can see that happening in these projected months on the outside here. Enrollment growth is slowing, which is going to be a good thing for the budget projections. The little graph on the bottom left shows you the impact of that per member per month reduction in our budget. So dropping from $505 on average to $496 is a $68 million reduction in spending. So it sounds like a little bit of money, but over a population this size, it is a significant reduction. So our focus on driving that better quality at lower cost is paying off in terms of a lower per member per month cost in the program. Slide 15, something we talked a fair amount about, the impact of Medicaid expansion and enrollment on our uninsured rate. You can see the orange line at the bottom, the increase in enrollment, and the uninsured rate at the top blue dipping down significantly. In 2015, about 15%. 2016, it's about 10%. We also track certainly a range of quality metrics in our system. Slide 16 is a selection of some of those. These are the HEDIS performance measures that are tracked across managed care organizations and across states. So we've seen from 2014 to 2016, more kids getting their annual dental checkup in the top left, more kids receiving their 6 well-child visits in the first 15 months of life, more women getting in for prenatal visits in their first trimester, about kind of flat, a little bit dipping in some diabetes testing on the bottom left, and better medication management for asthma on the bottom right. So we continue to track those and report those, and you see those regularly in our quarterly report. So with that as a foundation, then starting on slide 17, we began thinking about what Centennial Care 2.0 looks like. This is a 5-year waiver that began in 2014 and ends 2018, end of next year. But it takes some time to draft these, propose them, go through public comment, and negotiate a waiver with the Center for Medicare and Medicaid Services. So we began that process at the end of last year with a work group that many of the folks here participated in, and then have been out with a concept paper for what it looks like over the last few months, and we'll be issuing a draft application to CMS in September. So what I'm going to give to you today is what was in the concept paper and some of the opportunities we believe we have for improving this program, building on the foundation that we laid with Centennial Care first version. And they fall in these 6 areas. So care coordination, we talked some about behavioral health and physical health integration, long-term services and supports, payment reform, member engagement and personal responsibility, and that administrative simplification, and refinements to benefits. And we'll talk a little about that in more detail. So slide 19, some of the opportunities we've identified, I'll probably go through this fairly quickly. Happy to stop and talk about any one of them if you'd like. Really 3 key components here that we're looking at in care coordination. Really, how do we push care coordination down to the provider level? Something we set out initially in Centennial Care, recognizing that the picture of a member only really resides at the payer level. They could see when the person went to the hospital in Gallup but saw their provider and their hospital doctor in Albuquerque. That only existed really at the payer level. As data and systems become more integrated, as more information is available at provider levels, and as we can pay for services in a different way, we think there are opportunities to make and provide that care coordination that Steve's talking about to more providers in our system. Also a key component of this is improving these care coordination at transitions of care. So as individuals leave the nursing facility to go home, or leave the hospital to go back home, or are released from prison and jail and back into their communities, how do we connect them to healthcare services? Kids returning from foster home places. All of those places are key transitions for health and wellness that need to be managed in a better way to ensure we have lower costs and better quality. We also want to expand some of these programs working with high-need populations. So a lot of first responders and EMS systems are called to work with individuals on a regular basis. They're calling 911. How do we engage that provider system to be a part of the care coordination and the same goals of improving quality and outcomes? We're continuing to work with other care professionals, peer support workers, certified family support services, and continuing our efforts with community health representatives and community health workers. We have as a component of this also piloting home visiting in Medicaid, something I know this committee has been very interested in, and also are looking to expand supportive housing for populations because we know how important housing can be to health. Slide 20, a little bit about behavioral health integration. Really, we're thinking about how do we expand our health home model, which has been launching, as I mentioned, in 2 places, and also how do we support workforce development. We've talked about thinking about a way to pay for residencies in community providers instead of just hospital settings to both build the workforce in that community and maintain it. Slide 21, 5 different opportunities for long-term services and supports, many of which are directed at our personal care and self-directed services. The first allowing for one-time startup goods for transitions when a member moves from what's called agency-based personal care option services to self-directed services. So they're going to take on more responsibility for their care. They may need some additional startup goods for that additional work. Increasing caregiver respite hours. This is something we heard about from the stakeholder group that we had, and we were a little under what some other states were. I think there's an opportunity here to expand that. In order to maintain this community benefit that we talked about, we have that high share of folks receiving service in the community. We may need to limit some services, so establishing some limits, and we can talk about what those look like for certain services. The fourth there is implementing a nursing facility level of care determination that would be good for longer than a year. Instead of requiring an individual whose condition is unlikely to change to come back every year and have that assessment done, let's extend that for multiple years. I think that would be both better for the member and better for the system. And we also want to work with nursing facilities through both value-based purchasing arrangements and in helping them address what has become a higher needs population, including many behavioral health conditions, and leveraging Project ECHO to help them do that. In payment reform, starting on slide 22, really continuing some of the work that we've been doing, paying for better quality and value by increasing the percentage of payments that need to go out that are risk-based and value-based purchasing models. And then really using and leveraging these value-based purchasing models to pursue our other goals that we've talked about. So how do we pay for care coordination at the provider level? How do we improve those transitions of care? And how do we engage the providers on those efforts through different payment models? Slide 23, probably the most talked about component of our concept paper, laying out some additional member engagement and personal responsibility. We talked about advancing Centennial Awards, which we look to do. We've also heard from doctors and others that some things that cause them problems are no-show rates among Medicaid members who don't show up for appointments. So we are proposing to seek authority to allow providers to charge a nominal fee for free missed appointments. Very typical in commercial and other products, but something we think might be of value to encourage that member to at least call if you're not going to make the appointment or can't make it for whatever reason, lack of transportation or other reasons. And then we've also discussed and proposed in our concept paper premiums for certain populations. So at the bottom of slide 23, you'll see for 3 categories of eligibility, those above 100% of the federal poverty level, introducing premiums into the Medicaid program. So for those between 100 and 150, so between about $12,000 a year to $16,000 a year for an individual, $20 per month premium participating in the Medicaid program, and going up to $40 at the highest income levels, 200% kind of. we see here is a transition of the population into commercial products and exchange, in which they're starting to pay more. This is roughly about 1% of income is how these, or 2% of income is how these are roughly gauged. Slide 24 also looks at some simplification of the system overall. So we have today two different benefit packages for adults simply based on what their income is. So the expansion population, those above roughly 47%, at a poverty level up to 138, has what's called the alternative benefit plan. It's a plan designed as part of the ACA, a few more limits in the services available, and the traditional benefit package for those under about 47% of the poverty level for adults. We think there's an opportunity there to combine that and make one single adult benefit package for that population, and then allow an exemption for those who may be more medically frail to receive the traditional benefit package. This is both simplification for the system and the state, and a little bit limiting in what's provided. There are very few differences between plans, but something we can talk about in different questions. Slide 25, then. We have proposed, if necessary, if we don't have the state financing to support the program as it exists today, looking at developing a buy-in program for dental and vision services. So carving it out from the regular benefit package and allowing those who are interested in that coverage to purchase it. So that's something we have put in this concept paper. We have a lot of details to work out on this, but increasingly we've seen in the last few years an inability of the state to make the program necessary to meet the program as it exists. So if that continues, we would need to look at changes like this that could at least continue to provide coverage for those who are interested in that benefit. We also have proposed eliminating the 3-month retroactive coverage for individuals coming to the program. We proposed this 4 years ago. The coverage landscape post-passage of the ACA has changed. People are required to carry health insurance. There are ways to enroll immediately in healthcare at hospitals when you go in a trauma situation and get medical coverage immediately. That exists within the Affordable Care Act and in New Mexico today. So let's look at a way to simplify this and eliminate that 3-month coverage. We proposed eliminating what's called transitional Medicaid as well. Those whose income increases and they're no longer eligible for Medicaid, they've typically been put in what's called transitional Medicaid. So they get another 12 months of coverage. I think that's no longer necessary in the way it exists and the way it is operating as opposed to eliminating them. So all of this, Madam Chair, has been happening. Slide 26 is the timeline. We initiated the reforms in 2014. We began thinking about Centennial Care 2.0 in 2016. We'll be issuing our draft waiver application, as I said, in September. There'll be some opportunity to comment on that and look at that, certainly in the committee and the public, negotiate that, and actually procure new managed care organizations throughout the same time frame, and for readiness in 2018 to stand up a new program in 2019. And then, of course, all this is happening among some uncertainties at the federal level. So we had a slide in our public meetings that showed a lot of arrows going all over the place in 2027. But let me just give you a little bit about what we're thinking about in the next couple slides. As I said, Chuck did a very thorough job talking about the various financing models. But what's very clear is in the American Health Care Act, the Better Care Reconciliation Act, the Skinny, BCRA, or other proposals, financing for Medicaid is on the table, changing the financing for Medicaid is on the table, and to reduce federal spending on Medicaid in all the proposals. The budget impacts of these changes for us, and the way to look at it, probably most states are really 3 to 6 years out. So if you think about New Mexico, and as I just walked you through, we've had negative growth in per capita costs. A success of the program, I would argue with you at any time about that, how important that has been. But if we're set at a per capita level based on that success today, that's going to give us very little room for change in difficult for states like ours that have been more efficient in their Medicaid programs, and a per capita model is something we have to think about a lot. More immediately on slide 29, just some issues that I'm sure your staff is talking to you about, something that we're looking at, some FY19 budget changes that we're examining now. The expansion FMAP steps down again in January 2019 to 93%. Our regular FMAP rate looks like it's going to improve slightly. We'll see what the impact of that is. But in particular, the Children's Health Insurance Program is up for reauthorization and ends in September 30th, 2017. And it's unclear what Congress is going to do right now. They're not exactly moving together effectively, quickly on much of anything. So there are a few scenarios. They can either take no action and no reauthorization. We'll use up our block for our current CHIP grant for 2018 and have a big general fund need if we have to maintain coverage for CHIP in 2019 is a maintenance of effort requirement. There's a full reauthorization potential, which is probably the absolute best case scenario, but maybe not the likeliest, which would maintain a higher matching rate that exists in the Affordable Care Act, which has essentially taken CHIP funding in New Mexico to 100% of the federal level. There's one more year of that ability in the ACA. Congress have to reauthorize though for that money. The third is probably somewhere in the middle. They reauthorize, but maybe not the full federal funding level, and we're going to watch those scenarios and see what happens. Lastly, Madam Chair, I think something this committee and future committees and future legislatures need to think about is how do we restructure financing and responsibility for state and county healthcare. We talked about this a lot in the last session. The Medicaid program, with its expansion to some 270,000 individuals in this state, has alleviated a responsibility that the counties have had for a long time for indigent healthcare. Given that responsibility many years ago, they were also given taxing authority to raise money for those healthcare services. The Medicaid program has taken on that responsibility of providing that healthcare today, relieving the counties of that duty. The counties are doing a lot of great work, and isn't in any way to disparage the work they're doing, but I think at some point we have to rationalize the financing and realign it with where those services are being provided, and that's through the Medicaid program today and will be for the foreseeable future. I've also talked to you all about reducing the Medicaid's responsibility for other healthcare programs that exist for higher income populations, like the New Mexico Medical Insurance Pool, the high-risk pool, and the health insurance exchange. Today, the Medicaid program is largely paying operating budgets of those organizations in the assessment and losses of those organizations. That's something that's been difficult for us to continue to do. Finally, and I don't have a slide on this, but it's something I think is important for you all to know, and we've talked to you all about this before, is our work to replace our Medicaid management information system and work that we call HHS 2020, really bringing better data analytics, better look at population health, and a more modular system that we think can be more nimble going into the future. Something we've been working with providers and payers on, and something we'll continue to do in the future. So thank you very much.
All right, well, thank you, Cal. I wanted to ask, though, Grant, do you have a high-level comparison that the committee could look at of what we currently have versus what the proposed changes are?
And the proposed changes at Congress
No, your centennial care changes. The proposed plan that you put forward, you have a high level where you may not have it right now, but we need to get something like that. It shows what we currently have versus what you put in your white paper.
Certainly, we can put together a summary if you'd like, if the committee would like. We have a concept paper that has a lot of detail. It's not a high-level summary. This is more of a summary of that we can use.
Yeah, I'd like to do that because ultimately I'm going to ask the committee to consider providing comments in the comment period. That engages the committee clearly on what those proposed changes are going to be. All righty, let's go to the people we have. We have 4 people on the list. Currently, to start with Representative Crowder, and I'd ask that we have very brief responses. This is a heavy lift here with this department, but we got some time limitations this afternoon, so if you would, go ahead.
Thank you, Madam Chair. Just three very quick questions. The first two are for Secretary Ernst. And they're on page 13 and 14 of your presentation. On page 14, I noticed that by reducing the per person amount from 505 to 496, you're reducing spending by 68.2 million. And that's also reflected on page 13 in the lower right-hand corner under your per capita medical cost per program. But up above that, you made the comment that our growth in the past 12 months has been 5% growth in the number of enrollees. And as I look down through the numbers below, it appears to me that the growth has increased your cost by 147 million. But if you're saving the 68.2 million, then the net effect of your growth and your per capita cuts is going to be an increase of about 78.8 million. Is that a fair assessment?
Madam Chair, if I work those numbers the same way you just did, but it sounds about right. I think just to be clear, the $68 million, I calculated that just to illustrate what the per capita change would be. Had we been paying $505 per member per month with our enrollment in the current period, we would have spent $68 million more. So if we weren't able to bring down the per capita cost at the current enrollment, we would have been paying $68 million more. So they don't exactly foot to the numbers on slide 13, but that's illustration.
Okay, but what I'm trying to get to is there's a net increase in the.
So if you look on
somewhere in the neighborhood of $79 million. So, and I was just looking down here where it says $3,404 million versus $3,551.
right,
And those are the two numbers I used.
and just below that, 3.96 billion in the previous 12 months to 4.1 billion in the current
Okay.
12-month period. That's the spending growth, about 4% total change between
Yeah.
those two periods.
Thank you, Madam Chair. Just to help me understand this, there is a net increase in.
Oh, absolutely. With our enrollment growth, there's growth in spending overall. Absolutely.
Just want to make sure. The other comment you made was caused me to begin to wonder, where's healthcare going? Is it going to be all telehealth before long? And you know, I see that in the colleges and the universities that more and more people are going to school online. And I began to wonder if you made those comments, is that where healthcare is going? Is it trending toward telehealth?
I'm sure other panels can comment on this too, but I mean, technology has a way of disrupting all systems. Healthcare is not unique. I think there are many ways it can be improved. We've seen telehealth as one component, but increasingly, face-to-face visits, primary care and checks happening now, but across the system, looking at data more holistically, looking at population overall, all of that I think can be impactful. And I don't know if others want to chime in.
I missed your answer in there.
I think there's more telehealth. Absolutely, I think there's more telehealth. Yes, and I think particularly for a state like New Mexico, with its great distances between providers, where you have a great number of specialists in Albuquerque, fewer specialists in rural settings, telehealth can continue to be very important.
Thank you for that answer. And then my last question is for Mr. McKernan. I very much appreciated your new model that you built and worked on for the past 20 years. You drew me into that because I've experienced some of those things. I've had doctors say, don't come back until we get your blood test back. Don't come in until your biopsies are back. And those are the things you're saying was we're going to be much more efficient. And you made the comment that our model is working very well. Your follow-up comment was, we lose lots of dollars on Medicaid and Medicare. And I thought, well, if your model is working very well, why are you losing a lot of money over here? Do you have a model that's designed to be a one-size-fits-all and it doesn't work for Medicare and Medicaid? Do you have multiple models? I'm just trying to understand those two comments back to back threw me off track.
Madam Chair, Representative Crowder. Yes, there is a dichotomy there, and I tried to make that. We believe the model we're building is the model we're going to need to treat patients in the future, especially people with these critical, complex illnesses. And the current reimbursement schemes of fee-for-service do not adequately reimburse that. What we see is it takes years, almost decades, to build these systems. And so we got going on building them 10 and 20 years ago. But the reimbursement mechanisms have not changed yet, and therefore we lose money. I'll give you an example. We build a new community-based clinic in Albuquerque. It's going to have like 22 exam rooms in it. It's going to have 6 or 7 providers in it. We'll see 25,000 patient visits in it. It will cost us about $2.5 million a year to run it. Our reimbursement at the current fee-for-service mechanisms will be about $1.5 million a year, and we will lose $1 million on each clinic. What we believe at UNM is that if we had not started that mechanism, all the things that are being designed by Human Services Department and by companies like United, you cannot build those overnight. You can't switch them on. It takes years to train people, buy the equipment, the IT systems, So we got started on that. Now we're trying to work out with the MCOs and the insurance companies different reimbursement mechanisms so we're adequately paid for that service. That is a big lift to convince people to change those reimbursement mechanisms, one, and two, to have these sophisticated models where when you attribute a patient to a clinic or a doctor, the patient stay in that clinic and with that doctor and just don't roam around. That's hard. And if patients can just roam around to any clinic and don't stay in the clinic they're assigned to, then the system doesn't work.
Thank you, Madam Chair. And just one quick follow-on to that. You said the reimbursement is not caught up with the model yet. Is that a true statement in both private sector, private insurance, private pay, and Medicare, Medicaid?
Madam Chair, Representative, yes, it is.
Okay. So
Nobody's caught up. In our market in New Mexico, nobody's caught up. They're doing it in other markets, they're not doing it here in New Mexico.
okay, so this is a New Mexico issue.
And a lot of other states, but when you're in big urban places, like if you're in San Francisco or you're in LA or some of the big cities, Boston, they figured this out. We just haven't brought those systems here, and we could get into, it'd be a long answer, and I want to respect the chair. I can get into why, but they haven't made it to New Mexico.
Thank you, Madam Chair.
Thank you, sir. Let's go to Senator Liddell.
Thank you very much. And I want to thank you for the presentation, and most of my questions have been answered. Just a couple, make sure I've got it clear. There will actually be 3 types of coverage. You're going to have individual coverage. You're going to have individual coverage that is partially paid by Medicaid. And then third, you're going to have group coverage, which is a free enterprise. Am I correct on that? You got the free grant?
Generally, yeah, see, there's individual coverage that's subsidized through the exchange, group coverage, and non-subsidized coverage in the commercial market.
Okay. And I think that's everything for now. Thank you very much, and thanks for the presentation.
Thank you, Senator. Senator Ruth?
Thank you, Madam Chair and gentlemen. Thank you for your presentation. I've got a really quick question for you. On page 19, number 2, you talk about improved transitions of care, and you make reference to more intensive care coordination for members released from jails and prisons. Can you talk about where we're at now with that, and what your plans are in the future as far as these folks having the Medicaid process and our options for healthcare explained to us and come out and getting a little tutorial. This is something that I'm very interested in right now, along with criminal justice reform. This is a part of that on the back end of this thing as folks come out of the system.
Madam Chair, and I'll be brief, and happy to talk to you about it in more detail offline. I know Nancy Smith, Leslie, our Medicaid Director, can give you some more detail too. We have a system in place working with prisons and some county, particularly Metropolitan Detention Center and Santa Fe, to do presumptive eligibility, get them enrolled in Medicaid before release, and it's more difficult in the jail settings. You don't always know release dates. And then working with care coordination to not just get them into Medicaid, but also coordinate care for them when they're out of jail and prison. So one of the things we want to do in the second version of this is to allow that more intensive care coordination, not just eligibility services, but care coordination before release to better understand what the person's going to need when they leave and start better connecting them to healthcare when they're out.
Very good. Thank you, Brad. Thank you.
Madam Chair, might I take a second to address that also? In Bernalillo County, at UNM, we have a joint venture going with the county in which the county's developing a transition center. We are hiring intensive nurse case managers. So as people are coming out of the jail, their first transition point will be in the transition center. And then we will try and match them with a patient-centered medical home and a substance abuse center and a psych center if they need it. And then start the patient-centered medical home with the navigators and following up with those patients if they so desire.
And Madam Chair, just quickly, what is your projected time? You say you're developing this. What do you project for rollout on?
Madam Chair, we're hiring the people now. I think the county is expecting to go up in about 9 months or so with the transition center down at the old jail center, 4th and Roma, and that's where we're going to focus all our efforts.
Very good. Thank you. Thank you.
Thanks, Madam Chair. Mr. Roman, thanks for the presentations. I was looking at the block grant, and I was looking at your organization, so what responsibilities to pass and providing this information to Congress and GAO. There's also another bill concerning the block grant that's been introduced or is talked about that would look at the block grant for Medicaid for states. And I don't know whether that's determined on the predetermined formula, or is that, you're not talking about that in your page 4 about that predetermined formula. This is what actually the House passed, previously. Is that correct?
Madam Chair, Representative, the House passed version included a state option for block grant that had a specific kind of, base year and trend and all of that, with specific mandated populations, mandated benefits, and then otherwise state flexibility. That's not what I was getting at on slide 4. What I was getting at on slide 4 is just at a more general conceptual level, how a block grant typically works. And we've seen that with other grants from the federal government down to the states. So I was trying in those first slides to just frame up different financing reforms without linking it back to a specific proposal, and then I tried to describe the specific House proposal.
Well, thank you for that. And in this other one they're introducing, or supposedly going to be introduced in the Senate side, that talked about it, and it looked at states, some of the states who would gain and some of the states that would lose under the block grant. And states like Montana and New Mexico and some of this would be real gain, and California would be a big loser as part of that proposal. I don't know how much detail is out on that, but obviously MACTAC has probably looked at that.
Madam Chair, Representative McCrack has looked at that, and I can share some reports with you. I think in general, the trade-off of block grants is that most states lose financially in terms of federal funding, but they gain flexibility. I think that was true even for those states that you mentioned.
Good. And the other question I had concerning that is, when we were talking about the availability of the states to provide information, the invitation, if you will, that's kind of blurry to me as to what exactly that was about.
Madam Chair, Representative, that was the Secretary Price at HHS trying to encourage states to think about areas that may have been denied in the previous administration that were now kind of back on the table for CMS willingness to consider, like work requirements and drug testing and so on. Some states, Wisconsin and other states are pursuing these very things. So I think it was really Secretary Price's version of saying, there's a new sheriff in town and I'm open to things that maybe would have been non-starters before.
So that question goes to you then, Mr. Ernest. When you look at saying, now we'll look at maybe a little copay, maybe a little work requirement of some sort or something, and that's allowed, and we have not followed up on that? Or why is it now being relooked again or looked at it now?
So, Madam Chair, the letter states all states received, fairly brief, couple pages, I think, laying out this interest to receive proposals. We are just in our phase of waiver requests. Our timeline for waiver requests begins, as I said, in September. We'll be issuing an 1115 waiver request, which will include some of these components. Not everything that the states were invited to make proposals on, but things we think work in New Mexico.
And Madam Chair and Mr. Secretary, would you use that money to help with the budget, like $20, $30, $40? And I don't know how much that would generate, but is it where is that? Is that taken as a credit, or is it just where does a copay go in the budget process?
Madam Chair, Representative, there's two things. The copay, if you think of, and just to use round numbers, $100 is what is paid for service. If there's a $5 copay number required by the individual, the payment becomes $95. So there's some savings, if you will, on how much the service actually costs. That's very high. A premium is a reduction in what we pay the managed care organization. So let's say the premium is $300, but the PMDM, if you will, what we would pay for an individual is $300, but there's a $20 premium contribution for that. We would pay $280, reducing the state spend, the individual having to provide $20.
Thanks for that. That gives us clarification. Madam Chair and Steve, thanks for your service. I don't know what your next step is, but we never retire. We just wind up, being into something else until we get to the point where we're saying, I don't want to do nothing anymore. And that very rarely happens to us until we get to the point where we say, at what point do you want to do nothing? So I don't know. The next step will be, someplace where you can help New Mexico in one form or another. So I would assume that that's in the back of your mind after a good vacation and a rejuvenation of 3 days or 4 days to get back into the saddle again.
Thank you, sir. Yes, that my wife and I are staying here in New Mexico. She's a native New Mexican. We have a lot of relatives here, and we're here to serve. So we're going to take a little rest, and then we'll be back.
Well, congratulations, thanks for your service.
Madam Chair, is it okay if I just also supplement?
Just quickly.
Well, it'll be quick. I promise. About the premiums, Representative, states that have done premiums, I just want to make sure that the LFC doesn't overstate what might be saved. Okay, so let's say there's premiums and people have to pay $20. That could reduce the payments to the MCOs because we're expected then to collect it from the member. Some states have then seen enrollment reduce because if people don't pay their premiums for some number of months, they're disenrolled. But what that means is, so some states might model, you're going to have a reduction out in enrollment and there's going to be savings because of people not paying and dropping off the rolls. But what the people who drop off the rolls tend to get healthier, and this is what MACPAC has seen in other states, which means that the per member per month for the remaining people tends to go up a little bit because it's a sicker group who stay. And so you have to take all of those factors into consideration. So I just wanted to be very careful in how you all think about simulating the effects of all of this. Thank you, Madam Chair.
And thank you for that. And obviously, I'd comment a little further on that. You have to have real good coordinations with the providers to make the collections, of some sort, if it's premium or a collection at that point. We've seen it where collection was, I'll give you an example, the public defenders were supposed to be collecting people from, to provide them services for indigent people, and we're in the hole, $35 million in that area, and no one collects it. So you gotta make sure that, that you structure it well enough that it does work, and that is working with the providers, if that's the direction that we go. Thank you, Madam Chair.
Was that your definition of retread? Thank you, Larry. Senator Sisnetos.
Thank you, Madam Chair. Much of the presentation, Charles, was relative to the legislation, both the House version as well as the Senate version. My question goes more so to the letter written by Secretary Price. In light of the failure, if you will, of adopting the legislation through the congressional process, does the letter allude to the potential or possibility of curtailing funding through administrative action of the Secretary? Did that come into play at all in terms of the whole scheme of things? Because that seems where we're at now, and the dialogue has switched from legislation to the possibility and the potential for administrative cuts rather than legislative action.
Madam Chair, Senator, so the administration cannot change the federal matching rates, the FMAP. They can't change those rules. They don't have that authority. They can do certain administrative actions that can make the funding levels of the states go down. They can do more audits. The Inspector General at HHS has been very active looking at whether states and providers and plans and all of that are doing fraudulent activities. They can scrutinize the cost reporting that states submit and say, this was bucketed wrong, we should have been disallowed. So it becomes more of an audit function. The Secretary lacks the authority to fundamentally change the FMAP, matching rates, structure of the program. So it becomes much more of a hand-to-hand combat with the states about auditing.
Appreciate that. Thank you.
All right, thank you, Senator. Thank you, gentlemen, for a light presentation this afternoon. We know we're going to have you back in front of the committee, not Steve, but the rest of the group will be back. And I would be looking for the high-level comparison, and as soon as we can get that, Brand, I appreciate it. Send it on to the staff, and then we can take a peek at it. I think next month, then we'll be looking at possibly the committee weighing in and making some comments of our own. So thank you again, gentlemen. I appreciate you being here, and congratulations on your new time. All right, looking now at the agenda, we have some miscellaneous committee business to look at, and first is going to be our minutes from July.
I would move adoption if there are no changes, additions, or deletions.
Okay, we have a motion, Senator Sisnetos, second by Representative Hall. I do have a question on the minutes. And I can't find it in here, David and staff, but I did make the motion that we send a letter to PRC, and when I signed it that day, I know it was sent, but it's not in the minutes. But where is it? What are we? I mean, the committee vote is, okay, because that was a joint committee action. I want to make sure that that's documented.
Can we just make the motion to approve the zero points for the minutes?
So we're down to Madam Chair.
Now, let's not, go ahead.
Second.
Go ahead.
He's amending his motion. For the structure.
Okay. For the members that weren't here in July, we had voted, both committees were unanimously that we were going to send a letter to the PRC in regard to this plan that's being done up there. for the San Juan generator. And I want to make sure that that gets documented in our minutes because that's quite a big deal for us. So noting that particular change, is any objection to the approval of the minutes? Seeing that, we are approved. The next item is our budget guidelines. And that's tab E.
We've had a lot of thinking about budget approaches. In the last number of years, we've had a lot of interest in performance-based budgeting and accountability, and the report cards are a critical piece of that. Also, more in the last year, we've heard a lot of conversation from teams, which has been very helpful about what they call results first. The results first is a fancy name for doing cost-benefit analysis to make sure programs are effective. And I went to a key sponsors meeting of the state LSC directors last week, and she was there, and they really liked results first. Results first is a tool. Performance-based budgeting and report cards are a tool. Even incremental budgeting is necessarily a tool, and even zero-based budgeting sometimes. So these budget guidelines, I think we got some recognition from the few folks at the meeting last week. They like seeing that we're talking about results first in there, but also there's a recognition that results first and cost-benefit analysis is a very good tool, but you need the other tools like report cards. And that's where we are with this. And then Mr. Slee just mentioned the fact that tomorrow an executive committee will hear a report on stress testing. And we can make a copy available to all the members. We could append it to the guidelines. We could post it on our website, and under any scenario, I think we would discuss it in budget document. So what's the preference, Madam Chair, on the stress testing? Append it to this?
Let's go ahead and vote on this first.
That's what I-
Bring that other stuff up when it's finished.
Yes.
Representative Crowder?
Thank you, Madam Chair. I just had a quick question on the committee of priorities. I'm assuming the executive committee or someone came together and made up this list. How did that list come together? I was just curious.
These guidelines have been developed every year, and there's a continuity approach. So these priorities are ones we've used in prior years. Now, they start with staff making recommendations, and then the committee acts. So, this version was initially with my staff in conjunction with various members bringing forth a recommendation. As you recall, it was presented as a draft in Farmington a month ago, and we invited comments, and here we are now bringing it back for adoption. It's really just the first step in moving the budget forward because the agency budgets come in September 1st, and then analysts bring recommendations, and you have your hearings. These guidelines are intended to help give direction to staff for the kinds of recommendations that will be brought forward.
Thank you, Madam Chair, Mr. Chairman. I guess my one curiosity that I noticed was not in the priorities thing. As I've gone to Farmington and Grants and Silver City and Vegas and up here, there's no priority at all for any infrastructure, especially our roads and highways. And I wondered why there's no infrastructure priority at all.
Simple answer, these guidelines are oriented to the operating budget for hospitals. These are guidelines for the recurring appropriations. And infrastructure, LFC will have some recommendations, and we'll hear even a preview of some at the beginning of Ms. Kehoe tomorrow on capital outlay reporting. You'll hear that a couple more times through the course of the fall, but the capital outlay is kind of on a separate track from the operating recurring recommendations.
Okay. Thank you. Appreciate that explanation.
We have a motion on this. Representative Bernardo?
Madam Chair, I guess we're still talking about the budget request guidelines.
Right.
Yes, budget request guidelines, I think the very essence of having a stress test, similar to what Utah does in their budget process, I think would be a good, even if we don't have a, finalized in some way, I think there's at least some way we could start using that, in our budget guidelines to be able to help us budget better and at least have a better sense of what direction we're going with with the budget as we start that. Could we at least include that in, just in general terms, just as part of the guidelines down there?
I like that idea. Does anybody else have any problem with that? You don't have anybody with any problem on that, so David, this?
What I would propose, in some prior years, we've had a section on reserves. And I will propose to add a paragraph, I would propose to add a paragraph somewhere in subsection 5, budget guidelines, probably at the end, called reserves, and I think it's worth stating, to be good addition, saying the committee sets a target reserve level of 10% and say it's probably not achievable in the current budgetary environment, and make reference to the stress test which could be attached, and say that the near-term goal is to rebuild reserves and then use the information the stress testing to provide guidance to members on when to tap reserves and we get back to a higher level.
That's to be able to get it started somehow.
And with that, Madam Chair, I will move adoption subject to that revision.
All right, we have a motion. We have a second.
I'll second.
Second. We have a motion and a second. Is there any objection to that motion? Seeing none, it passes. The next item we have is budget.
For 10F, we have an appropriation, a recommendation from the staff, suggested Mr. Chairman, it's new to you all, and the budget request of the committee is due September 1st. So we have some time, and the committee faces the option to go with this recommendation or delegate it to a subcommittee or even have staff submit something that could be revised at a later point. But here's a first stab at it. We still have 3 weeks before it's due, September 1st. And here's a request for a 3% increase. And that's $123,000, 3%. And we're given a curveball in budget development this year that our workers' comp rates went up 35,000, which is almost 1%. And that's really unhappy for us. And somebody may remember we had an accident on the train in Chama with a tent pole hitting an employee in the head. And it's a claim figure that I proposed. And it reached unreasonable levels. But so our agency entered the unhappy world of dealing with lawyers representing an employee no longer works for us, works for another agency who is seeking pretty generous treatment from the state workers' comp administration system. So it's disappointing to me and it's expensive. And there was absolutely no negligence. Senator Bill also got hit by the darn thing. Much
And
worse.
he's here.
And that's almost 1% of the 3% of workers' comp. So it's really disappointing because that's not a productive expenditure, but it's something we have to pay. We have FY19 is a 60-day session, and so there's about 20,000 more expenses in a 60-day session for FYR analysts for a 60-day rather than a 30-day. And then we have a proposal to fill a vacant FTE analyst position. I'm probably not going to do for the current fiscal year.
It's pretty basic. We went over it yesterday. I sat in with David and went through this when we were going through their audit with their auditor, just to see the engagement piece of it. But he went through this with me.
And I would add one last thing. This is spring training in effect for budget development, bringing the first request forward. Many of the veteran members know that when we get to December and have a better chance to look at all the other parts of the budget, it's customary for the committee to revise a committee recommendation as compared to the committee request. So this will totally be revisited in December, along with all the other budgets, to form an LFC recommendation as opposed to really a staff recommendation that the committee would advance approve as a right.
Senator Moon, you have a
Quickly, how many vacancies do you have right now?
I'm interestingly only one.
Just,
Well, on Monday, I have Connie Jorgensen coming right back, by the way, which is really good for us to have a veteran of 5 years come back to the committee. And we are filling a vacant evaluator position also. We have really three, but two of them we've made offers in the next week or two, not been filled, so I have one remaining vacancy.
I've heard three or
And
four.
so it's quite a change from last fiscal year, where we had 4 vacancies at the time, and we didn't fill them because we didn't know what spending cuts were coming down the pipe, and we spent a lot of money on contractors instead of filling positions. And we had a pretty significant conversion last year just because of the budget uncertainty and trying to control spending as part of the solvency environment.
Well, I was just talking to the staff on those days, just work, just so hard, you know, just so impressed and thankful for the work they do. No comments about you as being a slave driver or anything, but these people wipe the sweat off their brow all the time and not complaining one bit. So,
Great achievements in spite of.
thank you, Madam Chair.
Any other questions?
Move adoption, Madam Chair.
Senator Crowder, and then we'll take your motion. Go ahead.
Thank you, Madam Chair. Just a quick question for Mr. Abbott. The work comp increase should 36%. Is that any kind of indicator that the state work comp pool may have an increase in work comp rates? I know that this is part of the pool, and it all kind of drives up. Do we need to anticipate an increase in work comp statewide?
Not, it's single digits, low single digits, and you'll hear that going forward. I don't know the exact number, but that overall is in reasonable control. I think GSD is doing okay in workers' comp administration. This is just one bad look
I guess I'm not understanding why the one bad luck incident was all attributable to the LFC and not spread out through the state pool.
So the way workers' comp costs are administered is on a cost recovery basis. So we're not really actuarially insured for the risk. We are paying the cost from the pool and then recovering the cost in forthcoming periods. So in average, the state is controlling costs pretty effectively, but we had one adverse incident which, with the budget making practices of the risk management division of general services, they are making payouts and they're recovering the payouts on specific charges to our agency for the individual who worked here one time when the claim was initiated.
Okay, so General Services has made the decision to kind of recover from LFC.
They have decision.
It's just a method of management.
Yes. They have decision rules that basically say, sum up all the claims that happen by agency and recover them over a multi-year period and somewhat stable.
We have a motion, Senator Cisneros, we have a second on this. We have a second from Senator Birch. Is there any objection to this? All right, see no objection. It's been approved. We don't have this printed on our action item, but it's kind of an action issue. LFC has been working with LESC over the years, and we've been a great working relationship, and I had the opportunity to meet with the LESC chairman and with Senator Smith. And there's 6 people that we'd like to ask to work with LESC representing us, and that would be Representative Dodge, Representative Paul, myself, Senator Smith, Senator Cisneros, and Senator Medill. Is there any objection to that? These people have been pretty much, except for myself, have been the guiding light on this. Seeing none, we'll figure out people on the subject. All righty, review of monthly financial reports and informational items. Did you want to move
I
on?
want to hit a few real quickly.
Okay.
And then I think we're running slightly ahead, and we have a report card from the Taos School District, which is pretty typical. Last one we had from Farmington, Aztec, and Kirkland Central. But we ran out of time, but we're running ahead a little bit. So what I would propose is let's hold over item 4 for just a moment. I want to mention item 5 is that that's a,
Oh, we're getting feedback, David.
Yeah.
The
item 5 is the tab H. And the good news is one more year of status quo on performance measurement and reporting. Every year it seems we're concerned that DFA is trying to roll back reporting and roll back measures. There was some back and forth that was typical of other years, but ultimately we preserved the status quo, and I think DFA is positive about that. And you may have noticed in one of my activity reports in the last week that health proposed no longer to give a quarterly report as provided by statute. But the reason was because the health department has actually developed a computerized dashboard system, doing away with all the paper. You can go online, and in that computer system is a raft of information about evidence-based practices and monitoring plans to make sure the data is good. So health is taking this surprisingly to another level, a better level, on a paperless way. So bottom line, we don't have the struggle on performance measures and reporting that we've had for years. That's an information. At tab I, we have by rule of LFC, we're supposed to update our policy and procedures manual every 2 years, and this is 3 years now. You've just seen it for the first time, the summary of the changes. They all are internal to the organization. Those who want the 60-page document, ask Janae to get them either by email or paper. Next month we'll come back and ask for approval of the very minor tweaks to a policy that policy procedures manual that is housekeeping.
On the changes, we're changing from a biannual to a triennial reporting period, and I mean, you have a reason.
There's a requirement to renew and update it every 2 years, not reporting.
Oh,
The current policy says update it every 2 years. And it changes so little. It's worked effectively. I propose let's just do it every 3 years since it changes. It's not a reporting issue, it's just an updating issue. And so anybody who gets it and has feedback will get that. But in general, this is pretty minor ministerial stuff from my point of view. Bar report, cash balance report are in here. FTE report is worth looking at. I think it's at tab M. And we're down yet again on state employees. In the last couple of meetings, we've had a lot of significant conversation about the consequence. In general, state government is functioning pretty well for losing 15% of employees in 7 or 8 years. Government can work with fewer people, but there are problem areas that we need to be attentive to, including child protective services, corrections, where we had a violent incident in the last 2 weeks, and even as we heard this morning, tax and rep. So I kind of feel we're nearing the bottom of not greater opportunities to achieve savings in FTE reductions.
On that point, there is an assessment to be made as to how effective you can be with employees. I'm an engineer. I've designed bridges for 30 years, okay, or designed a highway. I don't do a design of a bridge the same way I did 10 years ago, 15 years ago, certainly not 20 years ago. And there's data, there is processes, there are computer programs and things like that help. It's the same thing with even tax and rent. When we talk about the tax gen they have, when we talk about, I know you still need people to process some of that. There's a way to be effective with less people and still do the job, and some of that process gets kind of lost in the process of looking at how effective someone is. You still need people. But how many people do you need? And the different counties that you need people more based on technology and things like that will help you do that. I don't know whether just saying more people is the answer for everything. It isn't. I can tell you, not in this world, not in the private sector, not in the public sector, not in research, not in academia or any place else. We were just talking about telemedicine being, a process in which you can do a process for providing medicine or providing analysis, by using technology in this way. And I think that's something that we've got to be, I think, aware of and consider how that is done.
I'm concerned about the direct service areas more than the back office. I think technology and computers have allowed significant savings in back office operations that are good for everyone. But when we're talking about direct line personnel and child protective service workers with 15, even this morning we heard on the early childhood report card, safety issues for our young children. And that's an example of where high vacancy rate for direct service workers for raise public health and safety issues. Prisons, 40% vacancy rate in number of the women's prison. So I'm in total agreement on how technology can help on office operations, but state police, prison guards, other areas of the U.S. All right, Mr. Salee, for item 11, the program evaluation status report, which is a tab.
So we're working on a couple of projects we're going to get pretty quick that came up in today's testimony. One that we're working on jointly with the LESC is an update on looking at our K-12 funding formula. And you all have done a lot of work as a legislature to pass legislation. Not all that's been enacted. Some of it relates to the school finance lawsuit with boosting that risk index. But there's other components of the formula that we had found to be problematic when we did a previous project in 2011, just administratively. And so we're following up on those. Those are going to feed into the subcommittee that Madam Chair talked about, and will be an information item for working with LESC on are there other kinds of changes that we need to make with the funding formula besides what we've been considering going forward. The next big project that we've been working on for most of this year is looking at cost drivers within higher education and looking at efforts to improve efficiency and reduce duplication, looking at our capacity of the system. Some of this will obviously inform you all, but it will also inform that task force that the Secretary is putting together looking at the governance issues, because we are looking at the capacity of the system, which basically we have an overbuilt higher education system, and there's questions about what to do with that. So I think it'll be helpful for you all as well to understand. We've taken a 9-year look back at how's higher ed been spending their money? What are changes in revenue? We've been looking at what we've been getting in terms of outcome, but in terms of cost drivers within the system, and I think there'll be some very interesting things coming out of that study for you all. We've been working with the judiciary very well on an impact evaluation of drug courts. This is an evidence-based intervention, one that we've found, if implemented correctly, has a good 4-to-1 return on investment. But we've not done an evaluation to see if we're getting the actual outcomes that research suggests we should be getting with drug courts. So we're hoping to be able to complete this outcome study by October. We talked some about the longitudinal student performance. We tend to look at student performance on a static basis, not whether or not kids are academically growing over time. What does it look like for a kid that starts out in 3rd grade and maybe not proficient, eventually they end up proficient, and what are some of the factors that could be contributing to that? We built this longitudinal data system that the state really hasn't used to analyze longitudinal data, so that's one of the intents of this project, is look at kids over time to see how they're doing. We've got another joint evaluation that we're conducting with LESC on virtual charter schools.
There's a handful of virtual charter schools. We're also looking at some school district operated virtual schools as well. But when it comes to virtual charter schools, their enrollment exceeds 60 school districts now. So they've grown to the point that they are larger than 60 of our school districts out there, and they're rapidly growing. They don't have the same kind of cost structure that traditional schools do, but they're funded at the same level. And we're also looking at outcomes associated with that kind of online learning environment. A new project that we're proposing to start is to take a look at Centennial Care, and the state's expansion of Medicaid to childless adults has resulted in a $100 million investment in behavioral health care services for individuals who either didn't have access to that before or had limited access through other funding streams. What are the outcomes from that investment that the state is making? And how is that impacting our criminal justice system, our broader healthcare system? Are those services that we're spending money on now that we didn't do that before making a difference for this particular population? We talked this morning about updating our tax gap audit and compliance project. These are, I'm in the middle of the page, our progress reports. You all have asked when we do our large projects, well, what happens? And so we're coming back a year, 2 years, sometimes more to say, here's the status of the implementation of recommendations. Are the problems solved? Or are there still actions that need to be taken? So we'll be looking at that issue you talked about this morning with the tax gap and how well the audit and compliance function is working at TRB. The committee asked us to take a look at dual credit issues. We've received the last data set, hopefully from NMSU and Doniana today, to be able to complete some of that analysis, and we'll have a progress report to you in Tier C next week. We're working hard on the early childhood gap analysis. What's the need? Where are services being delivered? What gaps exist? And what options do you all have in order to fill those, including methods of finance as well, such as things like Medicaid finance home visiting. And then we'll be following up on some other previous projects that you can see there at the bottom of that particular list. I'd be happy to stand for any questions.
Go ahead, Representative Crowder.
Thank you, Madam Chair. Just so I can have a full understanding when I go home on the very first item on here, 924 agency costs. When you say you're going to go through the funding formula issues update, are you going to reevaluate your data, run it through the formula, re-rank the schools? What does that mean when you're going to do that?
So this evaluation in the past looked at how our funding formula was operating. How was it being administered? How was it steering money? Did that match up with cost structures that exist in schools? Did it match up with good public policy? So for example, in special education, where we're trying to intervene early so kids don't need special ed, that results in less funding for school districts because they're delivering less service, but there's also a financial disincentive to do the right thing in that particular case. We've identified issues of gaming the system, frankly. School size adjustment is one particular area. There's a number of other areas where we found basically loopholes in how the law operated and recommended closing those loopholes. We've also found administrative issues with how PED was just administering the particular formula and flowing money. So we're going to be updating all of that analysis and prioritizing it to bring back to you all with any recommendations for further changes.
So when you say, Madam Chair, when you say you bring it back to us for recommendations or changes, at what point do you plug it into the formula and re-rank, where the schools are in the formula and how much they're compensated? How often is that piece at the very end adjusted?
Madam Chair, Representative Crowder, typically when we do make recommendations on changes to the formula, we will model what that would look like. And if you would need a hold harmless provision or how that would be impacted if you put a certain amount of money in to buy more units, for example. So yes, we do model that out, and it will depend on what we ultimately find with this project on how much of that modeling we need to do. But certainly before you take action on any legislation, we'll model that out.
So, Madam Chair, I understand though that the hearing is on September 17th. It says hearing date. When would we actually receive When could we anticipate the modeling to take place to plug back into the formula? I'm trying to get in my head, when may the schools back home feel the impact of the study you're doing?
Madam Chair, Representative Crowder, they wouldn't feel the impact until you take action towards with the governor to enact legislation. So we may be recommending a change to the formula, but ultimately that's your decision and whether the governor agrees with that to change how the formula works in state law, the statute. And then we can model that to help give you an idea of what the impact would be, for example, of increasing the at-risk weight, over a 5-year period. And we've done that on a regular basis, and if we have major recommendations with this, it will be included in the report. And usually the committee receives the report the day of the hearing.
Okay, so that's the hearing date and the deliverable date are the same?
Yes, this is just anticipating that within September of 2017 is when we're going to complete the project and present it to somebody. That hasn't been determined who will present that to or where. I think the subcommittee was looking at receiving this particular report, but it will be available to the public and members whenever they do.
Thank you very much. I appreciate your comments. Thank you, Madam
That's a
Chair.
good example of what this subcommittee will be working on.
We may have a modification from the courts too.
Alrighty, is there anybody else? Anyone else have any questions? Okay, if you don't have any questions, thank you, Charles. We're back on visit.
Number 4, and so Mr. Wu prepared a national forecast for the Taos school. These are customers who travel around. And if we have time, we'd like to talk about it. So we can take just a couple minutes to highlight the report. And then we have superintendent performance of the Taos municipal schools, and we'll talk very briefly about one.
Madam Chair, members of the committee, on tab G, you'll find the Taos Municipal Schools dashboard. Just 3 highlights for this report. In school year 15-16, the school district received a grade of D, a decrease from the prior year of B, primarily due to lower growth rates. Also, over the last 10 years, the school has experienced decreasing enrollment, primarily due to students going into the charter schools in the district. And the district recently experienced a record high graduation rate from 60 to 74% in the last school year. I'll turn it over to Dr. Torres for any additional comments or highlights.
Madam Chair, legislators, members of the RC Committee, thank you very much for allowing me to talk a little bit about Taos schools. I know it's been a long day, so I did want to just refer you to a couple of items and handouts that you have. We do have our strategic plan. It is the overview. It has 4 pillars, and all of our decisions are made around these 4 pillars. We are in the midst of transformation at Taos Municipal Schools. We have about 15 initiatives. This morning we had the YVI Taos Early Childhood, the Taos Early Childhood Academy that we did open up. We have 58 students. We have from toddlers up to 3 and 4-year-olds. So we do believe in early childhood, and we have many programs already in place for that. Also, you have a handout on the high schools that work. That brochure was created by the teachers. This is a 5-year program. We're in the 3rd year of our model. We are the only model in the state that is a full model called High Schools That Work. And those are career pathways where we begin working with students from the 9th grade, and they're taking the courses into whatever their interest areas are. So if they want to take the health pathway, they may want to be a doctor, a nurse, a veterinarian in that area. They might want to take the corporate, business, international pathway. They may want to take the engineering, the STEM pathway. And what we do is when they graduate, they not only have a diploma, but they have certificates. If they want to be in culinary arts, woods, whatever they graduate with, they have certificates of expertise to give them that much more expertise in competition. Most of our students do go to college, however, some of them go into vocational. So we do a lot of vocational training. And with this diploma, we also have the biliteracy diploma. Students can get their diploma in English and in Spanish. They can also get it in French, and they can also get it in Tiwa. And the Taos Federal will certify students that have the Tiwa language diploma. This year, we're actually opening it up to all languages. So if you are a Latin speaker, for instance, you can get a Latin diploma. So we do have some unique programs in Taos, and we continue to move forward, and we have just a lot of great programs going. So at this time, I'll open it up for questions if anyone has any.
Here we have some on the list. We'll start with Senator Smith.
I think we have the answer when we talked about the declining enrollment. On that, I wanted to know what the enrollment was for the schools. But it appears that enrollment for the last few years, collectively, between the two states, pretty flat around close to 3,000.
Correct. We have about 9 charter schools around us. We have 3 that we authorize, 3 that are in the state, and 3 that are around our area that our Taos students attend. So we lost about 1,000 students. This is the first year we've been looking to doing a lot of public relations to try to work, increase our enrollment, and this, we've increased it a little bit every year. This year, for instance, at the high school, we had 90 more students. The middle school, 30 more students. Enos Elementary has now a little over 600 students. And so we are getting a lot of students coming back to us. Now, we've had teachers that have done a lot of professional development. We have national board certified teachers, and we had 22 candidates last year. We have 12 of them waiting for to see if they've passed their exams, and so we are growing national board certified teachers, and we're doing a lot to, in combination with the public relations, we have really moved forward with our curriculum, and we've been fortunate that we are getting a lot of our students back.
What's the total number in the public system of charter that's participating in dual enrollment?
In dual enrollment, I would say about almost 200. We have the Friday program, which is the students actually go, UNM-Taos is closed on Friday except for high school students. So students from all around the area do get morning and afternoon dual enrollment. So they can actually graduate with an AA. They plus take all of their other courses. And we do have school on Friday, so they make up their classes on Fridays with the teachers.
What grade level is that participating?
11th and 12th right now.
11th and 12th. Has the 200 stayed pretty flat?
I would say so. We have tried to increase it a little bit, and we have increased it, but not by a lot. Every year we try to increase. So our increases have been not really significant, but.
Okay. Thank you.
All righty, Representative Gonzalez.
Thank you, Madam Chair. Good afternoon, Superintendent. Welcome.
Thank you.
I think for the members and on that this handout, the one that has the enrollment of 2008-27, that's doesn't include the 1,000 students that you talked about.
Right now we have about 2,400 students, but if you add in our 3 charters that we authorize, that's the 2,800. So 2,800 is our 3 authorized charters plus our own students.
And then the state charter schools is not included here.
Correct. There's, yes, that's not included in those numbers.
So that would bring it up to probably around 3,600.
There's 140 in one of the state charter schools, another one has 230, and the third one has, which one is the third one? It's 100 and some students, so it doesn't really equate to about 700, it's less than that altogether.
So overall, there really hasn't been, as far as within the district boundaries, the growth, because when I was there, we were probably right around 3,600. That we didn't have the number of charter schools that are there now. And I think one of the things, remember, that we have to be in is that anytime that you do have an application for a charter school, and several times the district, has basically not protested, but tried to have the understanding from the public education department that you can't split the pie that much and continue with the same facilities and the same infrastructure, and continue the operation, especially with the FTEs. And but every time it's being turned down and they're approved, and once they're approved, there goes another 200 students. And then plus the capital outlay requests for buildings and facilities, and it just goes on. And I just wish sometime that the value could go back again, to see, that there would be more effort, if we could just work together and just have stronger components and units, say at the high school and everywhere, instead of dividing the funding so much, that plus it affects transportation and all the other support services.
That's very true. So the pie is cut so thin right now. We have 1,000 students that we provide. They're on our football teams, all of our clubs. We have about 28 clubs at the high school. And so we provide mid-school, high school sports activities for 1,000 students. And it really cuts into the budget, but we just do the best that we can.
And also with the bonding capacity, it's pretty much been for some time. But now under the new part, that's also another one that draws to their portion, correct?
Correct. Like for instance, our maintenance, our SB 9 money, we do receive $2 million. So we've always had $2 million, but a couple of years ago when the policy changed, we now get $1.5 million. So we do have water issues. We do not have money for any maintenance of our schools. In our schools, we had a big break at Enos Elementary, and we spent $120,000 of our SB 9. And they're telling us that even though those pipes are 5 years old, that we better do some preventive maintenance and cut out all the concrete across, because if we don't, we're going to end up doing it during the winter, which is going to cost 10 times more. So that will probably cut into most of our, but we have many leaky roofs. We just don't have the money that we used to.
On that point, Senator Smith asked a question. Go ahead.
Representative Gonzalez, she brought up a point that you sort of spoke about it earlier on. A few years back, the Taos school system went for authorization to service their debt on bonds or gross receipts. How much of that debt does still exist? You know?
I'm not sure. I really cannot answer that. I'm so sorry, I can't answer that right now.
The argument was, we didn't have any other way of really accomplishing it, but it's not a real responsible way to fund operation of the capital investments on that. I understand the tax lighting, the property tax from that standpoint, and I look at what's being added to property values in Taos when you come out here. So we hope doesn't hurt it. Was there a sunset on that provision?
Madam Chair, Vice Chair, Those bonds are sold on a 10-year part.
When was that that we did
And
that?
the last one was done, I'm gonna say about like 4 years ago.
Did we sunset that piece of legislation?
No, it still requires legislative approval at the end of the 10 years. So it would come back, so basically it does have a sunset.
To the legislature?
Yes, that is correct.
How much was that bond for?
The bond, it's being done 3 times, which the first time was to build Holy Cross Hospital. And then the second 10-year term was, and that's not strictly for Taos, it's Cuesta Independent Schools, Taos, UNM-Taos, and Peñasco. And that 10-year one was completed, and then, so it's going on basically on the 3rd cycle, which at the end of this one will be 30 years. And it usually generates between 21 to 25 million on the 10-year.
Okay, thank you.
Madam Chair, thank you. It's very nice, very good information, and congratulations on the graduation part. I think that's really excellent. But just 2 more things for the committee to, I think that it's well for them to know is the Taos Municipal Schools for many, many years owned a very beautiful and very wealthy art collection that was through the process from way back, the early artists. And it was always a very hard thing for the schools because basically we didn't have the right housing for them, plus the maintenance, and plus the insurance, and so the whole thing was a very hard asset that the schools had for many years. And finally now it's being turned over to the Harwood Taos, and they're the custodians of the artwork, which I think is excellent that happened. The other part, Dr. Torres, that you don't have to provide an answer now or anything, but the Taos schools own a wealth of water rights, and I think it's very, very important to just really just stay, on the status, of where they are, what's happening with those, but it's a tremendous wealth of water rights.
We continue to do our best to keep our assets and then also stretch a penny to China and back. That's really, we have 17 grants. We continuously ask the community for help. And we're working closely with 27 nonprofit organizations. And so our funding has been from the community and from our 17 grants, and we continue to build our school district and continue to build capacity of our teachers. And it is difficult with the funding, I have to admit, because we really are we run everything on shoestring, but we still do it, and it doesn't matter. We almost, I think we lost close to $900,000 of our budget, and by the skin of our teeth, we were able to make it. We did sell furniture on the side of the road. We had to do a few things, but we were determined not to go on emergency money, and we really wanted to make it on our own. So it was a rough road. Last year, I have to tell you the number of hours that a lot of people put in to make ends meet, but we were able to do it, and everybody stayed strong and said, whatever happens, we continue to move this district forward, and that's what we've done, and we are on a roll. It's amazing. If anyone would like to tour the school, any of the classrooms, I'm so proud of the 400 employees, the 180 teachers that we have. It's just been an amazing experience. I'm beginning my 4th year here at Taos Schools, and I love it so much. And it's a privilege for me, and I just, the community and the support is outstanding, including my board. Our school board is incredible, so supportive, and child advocates. And so with them and our senator and Representative Gonzalez and Senator Cisneros, who completely continuously help us with moving our district forward. I think we're going to continue, and I'm very excited to see the results of our park and other school grades that will be coming in. So,
Thank you, Madam Chair. Thank you.
I had a couple of questions. Did you have something else, Senator Smith? The question I have is, I'm a new member on the Public School Capital Outlay Task Force and attended my first meeting this week. One of the issues around charter schools is eventually they have to be in the public buildings. So my question to you is, how many of the charter schools in your district are in public buildings?
One that I know of.
Okay. Have you been asked to house them?
They have their own nonprofit organizations, and two of the charters, they have their own nonprofit organizations, and the nonprofits are the ones that buy the buildings, and then they pay the buildings off. So that's the system they've used. We do have one charter that we do lease to. There's about 86 students. But the state charters, I think one of them just built a new building, and I can't really say how what that whole thing is about, because we don't really have any jurisdiction, or we don't have anything to do with the state charter schools.
The concern I have is that we've got this drop in enrollment, which would imply to me that there's empty space. If you have a bunch of kids that are moving out and moving into charter schools, it means that you've got space that's available. That would seem a little inefficient to me, that they would be out building new buildings when in fact there could possibly be buildings available. I mean, some of these sound like they were district chartered, is that correct?
As far as the district charters, one of the charters, for instance, started 15 years ago, and they purchased their building, and so they own their building, and they work it that way. And so they don't need or have not asked us for space. We don't have a lot of space as far as empty classrooms in any of the buildings. However, we do have one school that has 136 students. And so we do have some empty classrooms at Aurora Seco.
Well, I'm just looking at our chart and our information, Sonny can show her there on funded membership and personnel. And we're looking at that, that's a pretty big drop there in them.
600 fewer members.
Madam Chair, if I may just share a little bit on it. And, you're exactly right, that, it's a little bit more complicated than that. And to give you an example is when the Taos schools consolidated two elementary schools, Arroyo Seco and Arroyo Hondo, which neighboring right here, and built a brand new school, Arroyo del Norte. And then within just a couple of miles, you have a very large charter school that is in competition directly to, the area for the students that participate that go into there. And it's a very hard, situation, because if you look at the math and you look at the numbers, it seems simple. We have less numbers, but in equalizing the space, it's much harder to juggle around and to move around, but eventually it might come to that.
Yeah, my point on it, Representative, is I can understand the complexity. I get it. I'm from a rural area, but the reality is that they're still having to pay for it. I mean, they still have to pay for heating and air conditioning and maintenance and sewer lines and everything else. On that point, Representative Hall.
You were so right and you're so on target. And I think the suggestion, the two superintendents at APS, because they have excess buildings, and in this particular case, it could be an income generator for Taos School District, leasing that building or selling that building to one of the charter schools. So it's philosophical, I think, more than, I think Representative Gonzalez is right, but it's part of my turf, and I don't want to turn loose of it. I don't want to do anything to help charter schools. And I'm not pro, I'm just saying, when I had Bob Burrell look at statewide, a tremendous amount of vacancy that could be available to take care of that. And I saw it as an income generator, not to favor the charter schools or anybody, as an income generator back to the public school.
And what I got myself into, we had a small charter set up in a very remote area in McKinley County, and the school district superintendent simply refused to let them have the space. So they went out and did their own thing, got portable buildings, but that costs the taxpayer, that costs everybody when they do that.
You're dead on, lady.
And so, I mean, basically the superintendent didn't want to give them the space, is what it boiled down to. I don't know what the case is here.
We've never been asked for any space. We could probably move some students over to let them have these classrooms, but we don't have empty classrooms. Other than the small school that we have, the first charter that was authorized was about 15 years ago. The second is Taos charter. That was about 10 years ago. Representative Gonzalez might know more, but these two purchased a building, and that has been their building, and to try to move them, I think would be very difficult to force them to move, because they have a beautiful building, they paid it off, and when PSFA pays them, that is their money. So we don't have authority over forcing them to move or over their finances, things like that.
Representative Hall.
Madam Chair, at that point, you're not forcing. It's a business decision that you, the board, look at. Could we make some money leasing this, and as opposed to them approaching you, you approach them and say, we've got a business deal for you. That's what I'm talking about.
I think
And
it's
ATS won't
because,
even entertain that discussion.
I think it's because they already own their buildings, that they would rather keep the PSFA money to, and
Madam
those
Chair, I
are,
know this discusses with you all the time.
Yeah, I think that needs to happen, because I have a lot of questions about that too. We're not expecting the district to have any kind of policing responsibility. But in state law, at least from what I've seen, it says that at a certain point in time, they need to be in public buildings. And I think that's coming up in a year or two. Sonny, when does that happen?
Madam Chair, members of the committee, it's actually the deadline's of 2015,
Deadline.
so it's already passed. But there are a lot of exemptions for these charter schools, such as if there's a nonprofit dedicated solely for that school's operation. And also they can choose not to go into a building if it does not meet their educational needs. And so there's a lot of exemptions in the law currently that prevent it from having a lot of teeth in forcing charter schools to select public buildings that are available.
we do have one building, and it is a very nice building in East Grande High School. We lease that, so the building we do have, we do lease out.
Well, we appreciate your time here this afternoon. I appreciate the committee's hard work this afternoon. Thank you, Mrs. Torres, for being here.
Very much.
I think for the committee, we can leave all of our stuff here. You can leave your M&Ms here and everything. And we're going to report back here tomorrow evening, 8:30 tomorrow morning.
They'll be safe.